Thank you very much for the kind introduction. We can go straight away to the video, please.
It's incredible to think that some of the first attempts at developing a glaucoma drainage implant were published as early as 1906. We've come a long way since then and learned much about the factors influencing surgical success and complication rates related to GDIs. In this video, we discuss our experience with the armored glaucoma valve, or AGV, in Asian eyes and describe practical modifications in the surgical technique. While most tubes are placed in the anterior chamber, there's growing evidence that these have a significantly higher rate of endothelial cell loss compared to tubes implanted in the sulcus. Thus, the placement of sulcus tubes is increasingly not only preferred for eyes at risk of corneal decompensation, but also gaining popularity in more routine cases, as it almost eliminates the risk of tube endothelial touch. Traditionally, the AGV is placed under a patch graft or a scleral flap to prevent tube erosion. Here, you can see the creation of a 90% thickness scleral flap. A 25-gauge needle is used to create a sclerostomy 2 mm behind the limbus under the scleral flap, and the beveled tube is then advanced into the sulcus. In this instance, using a 29-gauge needle as a stylet. The Aravind group described a no-patch 4 mm scleral tunnel technique which had no tube exposures at 2 years in both adult and pediatric patients. A Mexican study with a longer follow-up of 8 years in 128 children who were implanted with AGVs using the same technique also reported no tube extrusions. Simply, a 23-gauge needle initiates a tunnel track starting from 4 mm behind the limbus and 2 mm lateral to the radial direction of the tube. The needle is advanced through partial thickness sclera for the first 2 mm until the entire bevel of the needle is covered. Then, the needle is dipped to enter the sulcus. These standardized measurements allow for a more precise and predictable tunnel creation every time. A highly beveled tube is then inserted into the tunnel and into the sulcus. We aim to leave the tube just visible in the primary position, or barely there, so it is only visible from a sideways view. Worries about getting the length of the tube in the sulcus just right can be circumvented by adjusting the desired extent and suturing any excess tube flat against the sclera. With this technique, tissue trauma is minimized, and gently curving the path of the sutured portion of the tube protects against vaulting, thereby reducing risk of erosion. Barely there sulcus tubes are especially easy to achieve when the pupil is larger and not as mobile. This is because a longer tube length in the sulcus can cause it to vault up, predisposing to iris incarceration or pigment chafing. Should a tube become occluded by the iris, an uncommon event, it can effectively be treated by laser iridotomy. To aid conjunctival closure, we advise marking the conjunctival opening at the start of the surgery. This simple step ensures perfect reapposition of the conjunctiva with no more guesswork, helping to guard against an untidy, uneven closure with a risk of retraction. Postoperative scarring remains a critical determinant of long-term bleb survival. Antimetabolites such as mitomycin C can be injected intraoperatively to modulate fibrosis, but it's also associated with non-specific cytotoxic and potentially severe complications such as bleb leak and conjunctival erosion over the tube. While our group's Cochrane review found intraoperative mitomycin C did not provide any benefits for the success of aqueous shunt surgery, most of the studies were conducted in Caucasian eyes. There may be a case for its use in eyes with higher risk of scarring, such as in pigmented races. At the 3-year follow-up, our local case control series of AGV with and without MMC found that after a single intraoperative injection of intratenons MMC 0.2 mg per ml, patients were twice as likely to be completely off topical glaucoma medications and also half as likely to be on 4 drops. There was also a significant reduction in the number of post-op glaucoma medications. No extrusions or infections in the group with MMC were reported, while there were some exposures in the group without MMC. These findings are similar to those from multi-center prospective double-mask RCT, the ARMED with MMC comparative trial. This showed that intra- and post-operative MMC resulted in better IOP control during the time period most vulnerable to a hypertensive phase, and cases required fewer glaucoma drops for IOP control at 12 months. In summary, we described several modifications to GDD surgical technique which have improved our surgical success and minimized complications. This includes marking the edge of the conjunctival opening at the start of surgery, use of a 4 mm long intrascleral tunnel, suturing down the excess tube length, sulcus tube placement where possible, and intratenons MMC injection. Thank you.
Thank you very much for the opportunity to present those. These are just little tips that we've learnt along the last 10, 15 years of doing these glaucoma valves. And I thought they would be useful to some of our colleagues in the region. Some of them you may have used already. In fact, the one we most recently used was the Arvin technique for putting our tubes in, and it stood us in good stead along the way. So thank you very much for the transfer of knowledge.